To introduce you, the clinical assessment of kidney function is central to the practice of medicine, and GFR is widely accepted as the best index of kidney function in health and disease. And an accurate value are required for the optimal decision making, because based on your GFR values, you are going to take decisions on various factors, which include medications, which includes dialysis, which includes future interventions. So all these are based on your value of GFR. Now, normally what we do in our clinical practice is to estimate the value of GFR. We are not actually measuring GFR from day-to-day practice. So first we do is estimation of GFR, or roughly evaluate the GFR, which may not be the accurate value but near accurate. So estimation of GFR is based on this particular investigation, which is the backbone of nephrology, which is serum creatinine. Now, serum creatinine is now widely used by various clinical laboratories, and in most circumstances, the estimated GFR is sufficient for you to make a clinical decision making. In other fields of medicine, first line tests are followed by more accurate confirmatory tests when needed. But here, actually, we are starting with this serum creatinine, and we try to estimate the GFR. Now, there's another method to actually evaluate the GFR, which is called as measured GFR. Now, here we are not estimating, we are measuring. Definitely, we need some markers to measure. Measure of GFR is more accurate. We use urinary and plasma clearance of some substances which is exogenously filtered, or filtration. You can say these are exogenous filtration markers, and these are the gold standard for evaluation of kidney function. But it's not routinely available because it has its complex protocols, complex ways of measurement. So you cannot, if you have to do this, you have to only sit with this investigation and evaluate, which becomes cumbersome for you and the patient as well. And it's not a very user friendly investigation. Though for various studies, when you need when you are using a scientific study, then you may have to use measuring GFR. But for all clinical practices, we are using estimation of GFR. So in day-to-day clinical practice, the estimation of GFR is required for these reasons. First, you have to assess the renal function. You have to assess the severity of the renal disease. You have to calculate the proper drug dosage, because you cannot give full dose for all GFR values. You have to actually measure the GFR, and based on various GFR, you have a proper dosage, especially for antibiotics. And appraisal of renal involvement in various systemic diseases. These are the important parameters where you need to estimate GFR in this patient. Now, renal function test is basically detects renal damage. It also monitors functional damage, and it also determines the various etiologies. So, what are the lab tests for renal function? Now, GFR, which I was discussing, but it cannot be calculated if you don't have these parameters, which is plasma creatinine. Then there are other values which can actually give you the function. One is urea. Then you have to see the urinary volume, urinary urea, and the minerals in the urine, which can be also measured. So test of glomerular filtration rate, GFR, you require these parameters to place. There are various formulas I'll be discussing in the further slides. So you need these values to estimate the GFR. One is urea, creatinine. Then you can calculate the creatinine clearance. You can actually estimate the GFR. And the recent test, which has just come in and is actually causing a lot of value, adding a lot of value to cystatin, to GFR, which is cystatin C, which is an early marker. Because we all know creatinine goes up only when your glomerular filtration rate is below 60. But you need markers which can go up before 60. So if you have a GFR which is going up at the level of 20, 30, 40, or till 60, cystatin C is a good marker for such situations, especially in the situations like acute kidney injury. So GFR, the volume of blood. What is GFR? Is basically the volume of blood which is filtered across the glomerulus per unit time. That's the measure is basically of the blood, because you all know kidney is the filtrating organ. It filtrates, it ultrafiltrates your blood. So what you're going to measure here is how much of blood is filtered by the kidney per time. So that is GFR in easy terms. So it is the best single measure of a kidney function. Normally, it is approximately, we have all read, it's around 125. It ranges around 100 to 130 ml per minute per 1.73 meters square of body surface area. So body surface area is also important parameters to estimate the GFR. Now it is determined basically by the net filtration pressure across the glomerular basement membrane. You know, there is a membrane in the glomerulus, and that is called as GBM, or the glomerular basement membrane. So it is actually measuring the filtration pressure with which you are actually doing the ultrafiltration in the kidney, and the permeability and the surface area of the glomerular basement membrane. These are actually the measurement which is coming in GFR. Now, you know, patient remains asymptomatic until there has been a significant decline in GFR, and that's the problem with kidney failure, because most of the patients say that I'm asymptomatic, and they fail to believe that they have CKD or they are in end-stage renal failure. So end-stage renal failure, or if you say CKD stage 5, or you say GFR below 50, the situations where you need to dialyze the patient, the pre-situation of dialysis, the patients are totally asymptomatic. So they present late in the emergencies or in the clinic in a very gasping or breathless state or uremic state. And that time it's difficult to explain them. That is a long-standing disease, and initially it is asymptomatic. Also, it's in common terminology, it's called a silent killer, because it doesn't have any symptom, pre-symptom, before the symptoms. So it remains asymptomatic till your GFR significantly declines below 15. It can be very accurately measured using gold standard techniques. Now, there are various techniques, clearance methods. The concept of renal clearance was actually introduced as a way of expressing the relationship between the excretion per unit time and the concentration in the plasma, which is obviously an index of kidney's ability to clear the blood of any substance. So that may be any substance. Basically, you have to measure the clearance of some substance, which can help you to measure the GFR. And you need a marker or a substance which can be of two types. One is endogenous, one is exogenous. Endogenous, we are measuring creatinine and all, but there are problems with endogenous marker because they also get reabsorbed by the kidney. But they have to be a marker which, when you're measuring a GFR, you have to use a compound or a chemical which can actually go into the body and get excreted normally, naturally. It cannot be reabsorbed, it cannot be resecreted. So such markers are very few. Now, what is an ideal marker? Is basically it should be produced normally by the body. It is produced at a constant rate. It should filtrate across the glomerular basement membrane, and it can be removed from the body only by the kidney filtration, not reabsorbed, not secreted. Now, there are very few markers, and possibly near easy measurement is creatinine. But creatinine has its own issues. Creatinine can vary from person to person. Creatinine can reabsorb. So probably you have to use some marker which you can exogenously give to the patient and can be injected. And the gold standard is inulin. Inulin is a compound which can be filtered only. It is not made by body. It must be injected, and you can measure the level of inulin in the blood and the urine, and then you can actually estimate the GFR. Endogenous marker, just discussed, creatinine, serum creatinine. It is produced by the muscle metabolism. So if a muscular person comes to you, his creatinine may be high, and that's high is normal. Whereas a lean, thin lady comes to you and her creatinine, even if it is normal value, is high for her. So you can understand that creatinine is a byproduct of the muscle mass. So more the muscle, more the creatinine, less the muscle, less the creatinine. So creatinine has to be weighed against the particular age, gender, and the muscle mass of the patient. So it is normally at a constant production in the body. It is filtered but a bit secreted. That's a problem, little bit problem with creatine, but it's okay. Urea is another endogenous product of protein synthesis. It is filtered, absorbed, and synthesized. Varies with diet also. So urea it has an effect from the food we take. Coming to the exogenous marker just discussed. One is inulin. There are others also. There's some non-radio-labeled contrast media which you can inject and you can measure them through PET scanners. You have radio-labeled compounds like technetium 99 DTP, which we commonly use in nuclear studies to actually evaluate the GFR. Now, talking about inulin, the molecular weight of 5,200 daltons is basically a polymer of fructose, and it is considered the gold standard for estimation of GFR. Why it's the gold standard? Because it's freely filtered by the glomerulus and is neither reabsorbed nor secreted by the renal tubules. It is metabolically inert and is cleared only by the kidney. It requires a constant IV infusion to maintain the plasma level, and that's the problem with doing inulin clearance because it's cumbersome. You have to admit the patient if you put him on an IV infusion, and once a steady state has been achieved, plasma and timed out urine specimen levels are measured for the inulin clearance. Now, in addition to inulin, there are other markers. These are non-radio-labeled contrast mediums. In addition to inulin, these are basically iothalmate or ioxol has been used for measuring GFR. However, it's not very common. And one advantage is that you have the urography and an estimation of GFR, which can be done at a single examination. You don't have to do multiple tests. But cumbersome measurement makes it unsuitable for day-to-day clinical practice because it itself is a procedure. So that becomes difficult in a busy OP practice. Now, coming to the radio-labeled compound, and this is actually practice because this is important, which can give you split GFR. Now, you have to understand what we are getting as GFR is a combined GFR of right and left kidney. But when you have to do transplantation, you have to have the GFR of single kidney to select which kidney can be offered to the recipient. In that situation, only radio-labeled GFR or the DTPA GFR can actually provide you the single kidney function. It can give you the separate GFR of right, separate GFR of left kidney, and a combination GFR of both. So a number of radio-labeled chelates has been used to assess the GFR in man, and as every small non-toxic compounds of amounts of the compound can be given and can be measured even at a very low concentration using conventional counters. Among these are basically 51 chromium EDTA, 125 iothalmate, 99 technetium DTP, and that's the commonest one which we're using day to day. 131 heparin, to mention a few. Now, these are depending upon the what area of the kidney you are interested, or if you are interested in the glomerular function, you are interested in the tubular function, you are interested in the scarring of the kidney, reflux, you have to evaluate. So, yeah, based on that, which area of kidney you want to evaluate, various radio levels radio level compounds available. I'm not going to detail on that part. But the disadvantage are that some radiation is definitely administered in this procedure, and radio pharmaceuticals are more expensive. Gamma cameras have their own problem. You need skilled personnel. Basically, you have to have a good distance of the gamma camera from the body surface area, and you should have actually a properly defined area of interest to evaluate the GFR. And these are more technically precise procedures. You need skilled personnel for them. Now, coming to the endogenous substance, or the one, or maybe the bread and butter for us, which is urea and creatinine. Now, urea historically is as a marker of GFR. It's freely filtered, but both are reabsorbed and excreted in the urine. So, reabsorption into the blood increases with the volume depletion. Now, if a person is getting dehydrated or bleeding or losing blood or plasma, in such situation, body or the kidney tries to reabsorb you. So in those patients, you will have higher urea, but you will have relatively lower creatinine. So there is something called urea to creatinine ratio. So in situations where there is a pre-renal failure, you understand what is pre-renal failure, anything which is happening before kidney, like dehydration, like volume loss, your urea will get exponentially high. And therefore, GFR may be underestimation in such situations. Reabsorption into the blood increases with the volume depletion, and diet, drug, disease all significantly affects the urea production. So maybe urea is not commonly used for GFR estimation. It is a product of the protein catabolism. It is filtered, is reabsorbed in the proximal tubule of the kidney. If sodium is avidly reabsorbed, so is urea. So that is what you see in prerenal failure. The FeNA or the fractionation of urea also increases in prerenal failure. So serum urea concentration is measured as blood urea nitrogen levels. A urea level can, as I've discussed, urea level can increase in volume depletion, dietary protein intake if it is short, if it is high, corticosteroid, tetracycline, and blood in GI tract of bleeding. In all the situations, urea levels can go high. Definitely, urea levels can decrease if the volume expansion is high. For example, pregnancy, liver diseases, severe malnutrition, they don't have enough urea production. So why does blood urea nitrogen increase? Now, when there's a GFR is going low, definitely blood urea nitrogen will increase. But there are other situations like increased renal reabsorption, extracellular volume depletion, and increased hepatic urea synthesis. For example, high protein feeding, corticosteroid treatments, example prednisolone, and GI blood absorption. What are the uses of blood urea nitrogen? It's not a very perfect marker for GFR reduction. It's a marker for adequacy of protein intake, possibly. It's a marker for presence of uremic toxins in chronic renal failure. Blood urea nitrogen ratio to creatinine reflects the extracellular volume status. 10:1 is normal. More than 20:1, there is a contraction in the extracellular volume. Then you have to evaluate why it is happening. So, definitely, you have to understand as urea is reabsorbed, so is sodium in prerenal failure. Now, coming to most important marker, which is used nowadays commonly, which is creatinine. It's a product of muscle metabolism. Some creatinine is of dietary origin, freely filtered, but also actively secreted into the urine. Secretion is affected by several drugs. Now, serum creatinine can increase if the body is a male body because of high muscle mass, if the person is on high meat in diet, if a muscular body, cimetidine and some other medication can also increase the serum creatinine level. What can decrease serum creatinine is basically age, female body, malnutrition, muscle wasting, and amputation where you have lost a part of your body and so is the part of the muscle. Serum creatinine concentration normally is between 0.7 to 1.4 milligram per deciliter, and depending upon the muscle mass, it can change. It is inversely proportional to GFR. That means the serum creatinine increases and GFR reduces. So, good way to follow the changes in GFR, but it's also evaluated by increase in the muscle mass or decrease in the tubular secretion. Measure of serum and urine creatinine levels and urine volume and calculate the serum volume cleared of the serum creatinine. That is how you have to measure the creatinine clearance. Same issues as with serum creatinine, except the muscle mass is there. Requirement of 24-hour urine collection. Odds are there for various variability and inconvenience is there. But there is another way if you want to do a perfect creatinine clearance or measure the creatinine clearance of a human body, then you have to use this 24-hour urine creatinine clearance. Now, that's a formula for creatinine clearance. It's basically creatinine excreted in urine divided by the unit time divided by the serum creatinine, and that's equal to basically your measuring the serum creatinine in the urine divided by creatinine in the serum multiplied with the volume of the blood. Now, therefore, it represents the volume of serum completely cleared of creatinine per unit time. Since the virtually all creatinine is cleared via the glomerular filtration, it's closely approximately the GFR of the human body. Now, what are the limitations of creatinine clearance? Only valid at steady states. It can change in different states like hypovolemia, hypervolemia, high protein intake, fever. So, serum creatinine may be stable. It must not be always stable. Now, there are drugs like trimethoprim, cimetidine, which can lower the tubular serum creatinine secretion and lower the serum creatinine clearance without changing GFR. So that's another compounding factor. If you have to see if the patients are taking such drugs, and it becomes more inaccurate for lower GFR values, very actually confused with these confounding factors. Now, GFR can be estimated by newer endogenous marker. Now, what are these new endogenous marker? One is beta-2 microglobulin, and the most commonly and now more talked about is cystatin or serum cystatin C. Now, talking about beta-2 microglobulin, it has a molecular weight 11,815 Dalton. It's filtered at the glomerulus just like water. It is subsequently more than 99.9% reabsorbed and degraded in the renal tubule. Because it is filtered so readily, its plasma concentration is in health is low. Average is around 1.5 milligram per liter. And the plasma concentration increases as the glomerular filtration rate declines, reaching about 40 milligram per liter in terminal uremia. So the logarithm of the plasma concentration is linear related to the logarithm of GFR throughout the whole range, so that it provides an excellent marker for renal dysfunction. The plasma concentration of beta-2 microglobulin is not affected by muscle mass, that's good factor, nor by the sex of the individual, so you do not worry about the gender. And its estimation involves a very expensive radioimmunoassay. It has not yet become more useful in the clinical practice. The only problem is the cost of providing this investigation for a day-to-day clinical practice. Now comes the serum cystatin C. Now, what is this cystatin C? It's basically 13 kilodalton protease inhibitor, which is produced by all nucleated cell, whatever cell which has a nucleus, and is independent of the muscle mass and gender. So that's the advantage of having cystatin C. Its production, is, unlike beta-2 microglobulin, is not affected by inflammatory states or malignancy. So you don't have to worry about these situations. Cystatin C is eliminated by glomerular filtration and is metabolized by the proximal tubular cells. It's measured by its measurement has been proposed as an alternative and more sensitive marker for GFR than creatinine, particularly patient with slight to moderately decreased GFR. So coming to the definition or CKD and the classification of CKD, basically CKD is chronic kidney disease. Previously, it was known as chronic renal failure, but that term has been removed by KDIGO, and now we call CKD a chronic kidney disease. Basically, it is defined as abnormality of the kidney structure and function present more than 43 months with implication for health. Now, there are various criteria either for following the present definition for 43 months. The markers of kidney damage are albuminuria more than 30 milligram more than 24 hours per hour, or you can have the spot creatinine ratio of ACR, which is easy to do in the OPD practice, which is more than 30 milligram per gram. Then you have the urinary values, like you can have urinary sediment abnormalities, you can have RBCs in urine, you can have cast in urine. Then electrolytes and other abnormalities due to tubular disorders, abnormality detected by histology, by the example is biopsy. Structural abnormality detected by imaging and a history of kidney transplantation. All these are markers of kidney damage. Now, decreasing in the GFR. Now, when the GFR is less than 60, then you can say that the patient is entering chronic kidney disease in a more active way. Now, staging of CKD. It's recommended that CKD is classified based on the cause, GFR category, and the albuminuria category. So we have three things now when you are actually staging a CKD. Now, assign the cause of CKD based on the presence or the absence of the systemic disease and the location within the kidney of observed or presumed pathological anatomical finding. So you have to assign the GFR categories as follows. In the absence of the evidence of kidney damage, neither GFR category G1 nor G2 fulfills the criteria for chronic kidney disease as per Kidney International 2013 article which was presented. Now, GFR categories in CKD, basically you go like this, G1 to G5. Basically, you're basing your classification on GFR more than 90, normal or high. You can say GFR is actually normal. Between the values of 60 to 90, you have mild decreased GFR, you are in G2 stage. G3 has been divided again into a fraction of 15, 45 to 60 and 30 to 45. where there is mild to moderate decrease and moderate to severe decrease in GFR. G4 is the pre-dialysis or pre-transplantation stage, where you have to prepare the patient for a proper renal replacement therapy, maybe peritoneal or hemodialysis or transplantation, where the GFR is between 15 to 30, with severely decreased GFR, and less than 50, you have the severe renal failure, where you need to start him in a proper renal replacement therapy. Albuminuria categories, you are again dividing the patient into A1, 2, 3 based on your AER or albumin excretion rate. If you can measure in two ways, one, you can actually measure that in 24-hour urine, or you can measure in the spot urine. The ones which you are doing in spot urine are commonly done. Now, if you are A1 is basically, you remember the factor 3, everything is 3 here. So below 3, 30, AER, you are in A1. When you are talking about at various units like milligram per millimoles or milligram per gram, it's less than 3 milligram per millimoles or less than 30 milligram per gram. These are normal, A1. Now, once you are crossing this A1, you're going into A2, the values of AER of 30 to 300 or ACR of 3 to 30 or 30 to 300. These are the places where actually you are having a proper microalbuminuria. But once you are having macroalbuminuria, where you are A3, where the staging is A3, the AER values are more than 300, or you have the ACR values more than 300. In such situation, patient is like in red zone. It keeps on rising. Creatinine can go higher, and these patients are prone for worsening GFR or increasing serum creatinine. Now, that is what I'm talking about, the red zone. Basically, this is based on the albumin excretion of the kidney. Now, once you are having G1 to G5, and you are based on the A values or the albuminuria value, and that is how the CKD staging is actually done. So, to summarize, creatinine clearance remains the most widely used test for estimating GFR in clinical practice. Despite its many disadvantages and problems, it is still the commonest way of doing GFR values. And you have to appreciate the limitations. GFR can be estimated with reasonable accuracy and precision from serum creatinine alone. With creatinine clearance, predicting formulas can be used. Serum cystatin C is coming up. It could be well into the clinical field as a routine method for estimating GFR in near future. Probably not today, maybe tomorrow when the things are not that expensive. Possibly this may be a day-to-day affair. Thank you very much, and over to you, Tanmay and your team. Thank you very much, Dr. Reddy, to provide us this opportunity to speak on this topic.
Thank you, sir. Thank you.
Thank you, sir. Thank you. Fantastic.
Yeah. Thank you.